We're going to talk about corticosteroid-induced glaucoma, kind of a short talk. We know that intraocular pressure can respond to all forms of corticosteroids. But it seems to be that the closer that the steroids are to the eye, the more likely they are to cause problems. So things that are inside the eye, like reticerts or intravitreal anti-inflammatories like Kenalog, have a very high likelihood of causing pressure rise, more than topical, which is more than systemic. And if we get very remote from the eye, such as an injection of steroid into the knee, the likelihood that it's going to cause a problem is pretty small. You can have endogenous steroid-induced pressure rise from something like Cushing's syndrome. Steroid implants have a high chance of requiring medical or surgical treatment for pressure control. This is a picture of a reticert. That's not where it belongs. This is one that had broken loose and had come into the anterior chamber. So you won't see this very often. But it's a good picture of a reticert, which is a depot steroid that's in there for years. If one challenges patients, which I wouldn't recommend, with a 6-week course of topical corticosteroids, most people don't have a pressure rise. So 2/3 of patients or individuals have less than a 5 millimeter of mercury pressure rise. But about 1/3 will have 5 to 15 millimeter mercury pressure rise. And some of those will have a really high pressure elevation, over 15 millimeters of mercury. And that's in about 4 or 5%. So these don't exactly add up to 100, but in broad strokes, 2/3 are non-steroid responders, 1/3 are, and of those, there's a small percentage that have marked steroid response. And this is to topical drops. It would be higher if we did intravitreal steroids. It's important to know that this can occur at any time, so one needs to stay vigilant even after the patient's been on steroids for a long time. Pathophysiology is uncertain. It may be the accumulation of glycosaminoglycans. More commonly, one will see this in patients who have open-angle glaucoma, and their relatives are more likely to have a response to steroids. And like primary open-angle glaucoma, the disease is asymptomatic until very late in the disease course, when they start to have field loss and all of the things that one would see in primary open-angle glaucoma. The treatment, it would be to stop or taper the corticosteroids. However, that's easier said than done, because hopefully the patient needed the corticosteroids for some aspect of care. Sometimes, I would say rarely, one can excise a depot steroid like this. But again, the steroid was placed there for a reason, and so I found myself only doing this once or twice ever. One can also use steroids that are less likely to elevate intraocular pressure, but the reality is the ones who do the best job of controlling inflammation are also the ones that are most likely to raise the intraocular pressure. So this can feel like a ping pong game. One decreases the steroids, the pressure gets better, but the inflammation gets worse. And so we ramp up the steroids, inflammation gets better, but the pressure gets worse. I found that it's not at all rare for me to do glaucoma surgery, such as placing in a tube shunt, like an Ahmed, a valved tube shunt, just so that the physician caring for the inflammation can do an appropriate job, use as much steroid as needed to control the inflammation. So the key points here: elevated pressure in response to topical steroids in about 1/3 of individuals. The closer you give the steroids to the inside of the eye, the more likely it is to raise the intraocular pressure. The better the inflammation control in general, the more likelihood of pressure rise. And it's treated mostly like primary open-angle glaucoma. So we'll see a lot of steroid-induced glaucoma, and it's often very hard to know what to do. If the patient still has inflammation, they're on 4-time-a-day steroids, it's hard to know whether to back down on the steroids or go up on the steroids. I typically would go up on the steroids to try to quiet the inflammation, but it can be very frustrating going back and forth.